Welcome. I would like to cordially welcome everybody who will be listening and watching this presentation from Poland. It's a great honor for me to present the overview on integrase inhibitors in CEE. Actually, this presentation was very difficult this year because there is no much of data and everybody is still under the COVID cloud. So it's very difficult to see how we progress. But what I have prepared for you is just the general overview of current guidelines, which are linked to the integrase inhibitor, review of the data which we know, some questions over the time which are pertinent questions for us, for Central and European and Eastern region, and some of our data on the subtype of evolution, integrase drug resistance, and just a bit of influence for the future long-acting injectables, which we know are not first line, but maybe they will appear as a first line in the near future. So these are my disclosures. I work in Pomeranian Medical University in Szczecin, Poland, and currently I'm presiding Polish Scientific AIDS Society. We know that treatment initiation timeline is consistent across national recommendations, both for the European countries and Central and Eastern Europe, in line with the updated guidelines of EACS, and everybody who is diagnosed with HIV should receive treatment, irrespective of CD4 counts, irrespective of viremia, and we know it from the multiple studies that this early treatment both holds the progression of AIDS, but also is anti-inflammatory work and has anti-inflammatory effect, both from the perspective of progression of atherosclerosis or other risks like cancers. This focus on immediate CAR-T initiation is especially important for people with lower CD4 counts, pregnant women, and primary HIV infection, with special considerations related of opportunistic infection, tuberculosis, and obviously elite controllers, where the benefit is not from the virological perspective, but from the anti-inflammatory aspect of the treatment. So these are the guidelines, and most national guidelines also support that treatment as soon as possible, as soon as practically implementable. So we know that optimal antiretroviral profile is evolving towards safety. So on one hand, there is a treatment efficacy dependent on both natural replicative capacity of the virus, so genotypes, variants, new variations. Some variants have slightly higher replicative capacity, transmitted drug resistance, and also emerging drug resistance, baseline viral loads, which can be higher or not, and immune deficiency. But now, as we almost have the current first-line drugs extremely efficacious, we focus more and more about safety, drug-drug interaction, lipid profile, but also cardiovascular risk, body mass increase, which is now the key issue, especially in integrase treatment and compartment penetrations. So if we look at the EACS guidelines, and most of the Central and European and Eastern European countries somehow have integrated at least part of these guidelines in their clinical practice, we could clearly see that most of the recommended first-line regimens are integrase inhibitor-based, either being it dolutegravir or bictegravir or raltegravir, which is QD or BID dosed, but these are the first-line regimens. Also, in this recent guidelines, what we could notice is the two-drug regimen with powerhouse of dolutegravir coupled with lamivudine for people with viral loads below 500,000 copies with HBs negative cases. And then we have a little bit of alternative, but all the recommended regimens are basically based on integrases. So the powerhouse is there, and this is consistent across Europe. So let's take a look how we, Polish, have integrated this in the 2021 guidelines. So as this slide is not translatable, it's in Polish, I will just very briefly compare it. The abbreviations are international, so no problem here, but you could see that also we have first-line treatments based on two-nuc regimen coupled with dolutegravir or coupled with raltegravir or two-nuc with bictegravir, and we have two-drug regimen, lamivudine dolutegravir, equally as EACS. Then in the first line, we have retained doravirine and darunavir-based treatments to have more treatment options. And many countries also follow this pattern, allowing for the more broad approach to a person, but still the cornerstone is based on integrase. So if we would focus on the immediacy of treatment in the CEE context, so we can now think about various speeds across various countries. So not everybody has access to baseline resistance testing. Also, the resistance testing requires some timeline to return, usually from 2 weeks to 2 months. It depends whether it's centrally purchased and centrally sent, or is it locally done. And also there is a gap in between HIV diagnosis and linkage to care. So the patient readiness issue, where we think, okay, will this patient support a long-time treatment, is less and less important. So what we are focusing on now is giving the drug early for it to be efficacious, to obtain U equals U, so undetectable equals untransmissible, and to limit the resource involvement. And this is especially important in the case of COVID and diverging resources to the fight with this epidemic. But on the other hand, we think, okay, what about loss to follow-up? What about migrants who might not understand the need of a follow-up and the correct drug use? And we think, okay, some people say that we are stigmatized when we are treated. I do not believe this is the issue anymore. And obviously DDIs, but the DDIs with the current integrase-based regimens are less and less important. So we also have to think that in Central and European countries, we have higher percentage of females. So we need to also discuss the family planning, contraception, acceptance of that diagnosis, especially in older female populations, and some of the psychological issues. So here, the very early treatment, and also with integrase inhibitors, might be a little bit deferred, but again, good active drugs will be of a very important use. The thing which is always coming up when we talk about early treatment and integrase inhibitor-based treatment is the tuberculosis. Obviously, in the region, the prevalence of tuberculosis is the highest in Europe. And we know about that. And we know that it depends, it is variable from region to region, and also it's variable by the transmission category. So MSM, IDU, and hetero transmissions would have pulmonary TB more common. IDU would have extrapulmonary a little bit more common, but then you can see that Mycobacterium is always the top of the top in Europe. So if we would think that initiating in our context of antiretroviral treatment with integrase inhibitor first line, so here we have the 5 integrase inhibitors listed, bictegravir-based regimen, cabotegravir, dolutegravir, elvitegravir, and raltegravir. We could see that bictegravir cannot be used, cabotegravir cannot be used, elvitegravir cannot be used, whilst dolutegravir and raltegravir require double dosing. This is potential interaction, but there are limitations. But on the other hand, protease inhibitors have even more trouble with that, with drugs not being co-administered. And we still have a lot of late entry. So from the perspective of integrase inhibitor treatment and tuberculosis, this will be an important issue, especially in injecting drug use populations. Also, we still have a lot of AIDS, even though in some populations it's decreasing, but IDUs, for example, tend to be diagnosed even later and later. So 35% of cases are still diagnosed with advanced HIV disease with low CD4 counts, clearly CD4 counts being the highest among MSM. And if we think about treatment efficacies, on the other hand, if we think about treatment efficacies, it's irrelevant what you start with, but from the perspective of safety, it's not. So this is the clinical efficacy. Also, this is not data for the Central and Eastern Europe, but it's the data for the entire, mostly Western European countries. But here, maybe it's not very clear, but you could see that the durability and probability of virological failure is low on this treatment. Obviously, this weight gain signal is something that we worry about, especially linked to dolutegravir, bictegravir, and coupled with tenofovir alafenamide signal. But here we have a data gap for the Central and Eastern Europe. So this really needs to be studied. Why? Because there may be significant genetic differences. We have seen it in various Western populations and American populations that these body mass differences on integrase inhibitors tend to differ. So this is an important issue as well in this respect. So what about evolving integrase resistance for the future? I have shown this slide last year. So we know that actually in 2017, we didn't have any major transmitted drug resistance to integrases. And look, these are our current data for the last 3 years. You could see that there are multiple mutations on integrase emerging, most of them being E157Q, which is not important from the perspective of a treatment initiation, but you can also see that we have some major mutation being present in the treatment naive populations. So how often is it? It's more or less 2%, but we go from 2% from 0 to 2%, which is obviously low, but it can be increased in the future. Obviously, the threshold to be worried is around 10%. We do not worry about it yet, and I don't think we will worry about it in the future. Most of these people were subtype B or subtype A, but it has to be monitored and thought of. So resistance pattern in the failing patients are also important. Because look, this is a sample of our patients who have failed raltegravir. And you can see that that there is a cross resistance between RAL and Elvitegravir, but some of them can't be salvaged, or they will be difficult to salvage with Bictegravir or Dolutegravir. So this also has a potential clinical impact for the future. So finishing this presentation, it's not first line, but we have to think about long-acting injectables in the near future. So we know from the latte studies, latte 1, latte 2M, that you could dose cabotegravir with ribavirin with a decent virological success, and that neither is superior to another. But again, we will be facing, and we face, practical challenges organizing subcutaneous injections with a necessity of a close 7 to 7 day follow-up. And every country, every clinic will be a slightly different world, difficult to harmonize, but it has to be thought of because it's a next step towards long-term patient management. And obviously, in the context of cabotegravir use, we need to be wary about the signal of A186 subtype, which is much more common in Central and Eastern Europe, and can actually be related to the decreased cabotegravir susceptibility. And please take a look. This is the evolution of A1 subtype in red. So it's becoming more and more prevalent also in our country. So thank you very much for this opportunity. And I would like to invite you to ask the questions. I will be trying to answer them all. Thank you.